Today what we're going to talk about is living moments and legacy, obviously. And I wanted to really set the premise for today's talk with this quote that I think it's from Hippocrates, but it's one of those internet quotes where we never really know. But it's more important to know what sort of person has a disease than to know what sort of disease a person has. And I know that this is probably something many of you have heard before, and it's going to be the common theme and thread that I put throughout this presentation because I think it's incredibly important. So we're going to talk about palliative social work. I work at, like I was said in my introduction there, I work at a community-based hospice in Windsor, Ontario, and I've learned from speaking at different hospice conferences that looks very different compared to other hospices throughout the country, or the province, just the province alone. So I'll set the kind of groundwork by explaining what my hospice looks like where I work at, and explaining what social work looks like in that context. I want to talk a little bit about the goals of palliative care social work from my perspective. A little bit about therapy, although I won't spend too much time on it because I'm sure we're all very competent therapists. But I want to talk more about legacy and life work, so we'll get to the juicy stuff near the end there. And only because I get asked this all the time, I will briefly talk about the implications for MAID because that seems to be on everybody's mind. So what does palliative social work look like at the hospice in Windsor, Essex? A lot of what we do, believe it or not, is actually advocacy and resourcing for community supports. That's a big chunk of the work that we do at hospice. So that might look like helping people get in touch with financial supports, because obviously finances change when there's a serious diagnosis. It could look at legal supports if they need help with wills and things like that. It could look at housing, partly because finances change or because they live in an apartment building or they're living in a place that's no longer accessible for them, so they need help finding new place to live. That's actually a big chunk of the work we do. So it's not always the second bit right here, which is that emotional support. Although obviously when you're a social worker, you're always a social worker at all times, so emotional support is a big thing as well. We help people when they've been diagnosed, so we support them with coping with the diagnosis, the impact it's having on how they're living each day, the impact it's having on their loved ones and their care partners and things like that. This kind of goes into facilitating final conversations and those types of things. And then bereavement support following death. So we use various therapeutic modalities to address anxiety and sadness, most often experienced by patients and families. But I find that the current undertaking of mainstream mental health is to fix, right? We fix something that's deficient or broken or abnormal, and that's the point of therapy. But when we think about end of life and we think about sadness and anxiety, what is there to fix? You sit with people, and of course you're anxious, of course you're afraid, and of course you're sad. So what happens is I find, and I'll pick on social work students because I'm now one of them again after a while, but I've always supervised students, or I've had students come in and I've mentored them and I've precepted them, and they get to this kind of crisis midway through placement at hospice, and I've been there myself, so I can speak confidently to this, of what am I doing? I'm not doing anything. I'm sitting there, I'm talking to people, I'm trying to provide emotional support, but they're still dying. So what's this verb of social work look like in palliative care and end of life? What is the goal that I'm trying to achieve when we all know the outcome regardless? And so what I do is I typically throw it back on the students, which is what us instructors always do. And I ask, what is the goal of palliative care? And the answer I almost always get, besides pain and symptom management, is a good death. So they often say, well, it's a good death, so we're going to support the person for that. So I want you to keep that in mind because that's a very important answer, and it's going to really play out as I go through my presentation today. I put this question very purposefully here, what is the goal of my practice? And I can only say that I work with 4 or 5 other social workers, and I can't speak to even, on my own team, I can't speak to what the goals are of the social work that they provide. But I want to talk about the goals of my practice at end of life, and see if I can inspire some new thoughts for the people in here who are working in palliative care. I guess I've been fortunate. I've been working at hospice for about 5-ish years or so, and I've never worked with somebody who's dying. And I say that and people laugh at me or they chuckle, but it's true, and that's because we only work with the living. You know, everybody in here only works with the living. And so I think the real goal of social work at end of life or palliative care is to inject life back into the room, because disease and treatment and trajectory of that disease, it really just eats away at the person and just almost replaces their identity. And so the death story people are able to tell is like that, you know, and the harder story for people to tell is who are they, you know, and what are the pieces of their life that the diagnosis can't or the illness can't touch. So I put on here, it's very important, there's a very big cognitive difference in thinking that you're living with a disease versus you're dying from a disease. And that doesn't just apply to the patients, but it also applies to me as a healthcare provider as well. And I hear people say, like when I go and I do these talks, or I even talk to people on my own team, and they say, well, that's just semantics. That's just semantics. It's not, it's perspective. And it completely changes the way that we can do work. And so there's a Stanford psychologist, Dr. Laura Carstensen, and she hypothesized that how we spend our time is in a direct relation to how much time we perceive ourselves to have. And if you think about looking through this lens of dying and this lens of death, how much time do you think people perceive themselves to have? And even as a worker, as a healthcare provider, how much am I willing to invest in somebody if I'm looking at somebody as, oh, they're dying from cancer? So it really goes both ways, because I think if you make that very important switch of looking at things through this lens of life, the people are able to, you know, they're willing to set goals. They're willing to listen to you. They're willing to try new things with you. And as a social worker, I'm willing to take risks. You know, I'll introduce things that maybe otherwise I wouldn't have introduced. Or I'll try and pitch this idea of legacy work or things like that, because I'm seeing this person as a living human being and that I want to learn about and I want to invest time into. There's a fundamental human need for us to have a reason to live. And I believe in palliative care, social workers' role and goal should be helping uncover that need and attaching people to meaning and purpose. So again, that'll be the theme that we talk about today, because I know it sounds great, but what's it really look like? And I'll get into that a little bit. The last piece I wanted to talk about is that thought of how do we leave people feeling after we see them? Windsor, I'll speak to Windsor. I know there's a couple Windsor people, Windsor, Essex. Is there anybody else from Windsor, Essex in the room other than the two up front? Oh, that's okay. Ontario continues past Toronto. But we have these great resources. We have community nursing agencies, which we have probably too many of them. We have hundreds of them. We have PSWs, you know, we have our CCAC, we have our LINs now. So we have all of these great supports. And what happens is we go into the home, we check in on somebody, how are you doing, how have things been since the last time I've seen you? Maybe I'll do my 10-point ESAS and make sure you're okay, or checking out your symptoms, and then I leave. And I come back and I see you in a week. I'll see you in 2 weeks. And we keep doing this. And, you know, and I come back and I see them again, and I might say, how's the anxiety been? Have you tried deep breathing? You should. And we do that, and then we come back again in 2 weeks. So what happens is it's almost as though we're leaving people in this cycle of just waiting for things to get worse. And so it's something that I'm very mindful of in the work that I do, and I think it's important that we stay mindful of that and wonder how are we contributing to this story, and what are we doing to make sure that we don't fall into that, I guess, trap. So again, like I was saying, the common end-of-life concerns are mostly sadness, anxiety, and they're the two that I'll speak about the most today. There's existential concerns, that fear of the afterlife, unfinished business. You know, anybody who's worked, well, I shouldn't even say has worked, anybody who's cared for a loved one who's been at end of life, everything comes up at end of life. So family histories, mental health, everything kind of comes up at the end of life. So it's really helping navigate through things like that. You know, the worry, the anxiety, or the fear of the well-being of the people that we'll be leaving behind, that loss of independence, helplessness, all of these different things are common issues that we want to address and try and resolve the best that we can when working with somebody in palliative care. And with therapy, I know I spoke about this briefly, but there's really no one-size-fits-all. I work with some very fantastic social workers, and I'll say this very nicely. I have one that is just, oh, I'm a CBT, I'm a purist in CBT. You're not a purist in CBT. You can't be a purist in CBT in palliative care. You can't. And to expect people to follow something that's a rigid kind of therapy when their health is doing this and when appointments are coming up, and you can't. So I really believe that it's good to have this eclectic approach. So there's different things I'll pull from different types of therapy. So I know I just picked on CBT, so let me try and help it out a bit here. I did talk about that cognitive restructuring of living with and dying from, helping people understand or at least notice the influence of thoughts and behaviors and moods and all that relationship. But then also another one that I do quite a bit is that idea of helping them work with the concept of identity. And so males, we're genetically kind of wired to be difficult sometimes, especially in therapy settings. And I find that we often base our worth on what we're able to do. So physically, I'm able to do this or contribute this or take care of this. And once I'm no longer able to do that, I'm not worth anything anymore. So a big piece of the CBT might be using it to focus on emotional worth and to figure out the different things that where their value comes from or where their worth comes through. That's not from a physical aspect. So that's a big piece. DBT I'm a very big fan of. Is there anybody in here who likes DBT or uses DBT? Yeah, okay, a few, okay, great. DBT is great because it kind of pulls in those elements. I just want to make sure I didn't change the screen. It pulls in those elements of CBT, so the cognition piece of it, but it also pulls in a lot of the great stuff of mindfulness. So it's really letting people or encouraging people to feel what they're feeling, but notice the thought that might be behind it, and not judging themselves for having that thought. So it's how do you help somebody to sit in that moment and sit in that thought, let it come, let it go, the idea of Teflon mind, which is a big concept in there, but it's great. It's very helpful. I love it. I use it quite a bit. Motivational interviewing, it's becoming very popular and sexy in healthcare. In fact, I know the LINS Healthcare Connect people are actually being trained in how to use motivational interviewing now, where it kind of came from that substance abuse kind of roots, and now it's moved into how can I use it in palliative care. So some different things that we want to resolve in terms of ambivalence in palliative care. The idea of when I'm being told, which us social workers get told all the time, oh, go get the DNR. They haven't gotten it. I don't even like saying DNR, I use AND, which is allow natural death, because I just think it's so much nicer to say. So go get the AND, and they're not ready to talk about it yet, but get in there and do it. Or they have an advanced care plan, they haven't done any advanced care planning yet, the doctor and nurse can't get them to do it, send in a social worker when all else fails. Or a chaplain. Do we have any chaplains here? No? Oh, we do, fantastic. Yeah, fantastic. So you get it, exactly. So we get those types of things all the time. Those referrals come in all the time. So motivational interviewing, it helps to help people resolve that ambivalence and change some behaviors in terms of their resistance to do those certain things, or to get into legacy work, which I'll talk about today too. So often you'll hear, I'm not ready for that yet. I don't need that yet. I'll know when the time's right and then I'll do it. But yet they have all this anxiety and this worry and this fear for what, their family and things like that. So you can use motivational interviewing in that sense. Expressive therapies, we have an art therapist who comes to hospice and does art therapy with our patients in the wellness center. We have a social worker who focuses on play therapy with the children, which is fantastic. I will never offend a music therapist by saying I do music therapy, because I don't. But I do play guitar, so I'll use it when I'm working with people as well. But we've had some amazing help from the music therapy program when it was around at University of Windsor. So they've come in and done some great stuff, which I'll talk about. Narrative therapy is also something you could use in terms of that storytelling and kind of creating new stories or creating meaning from somebody's stories and life stories. I think regardless, I have always been very humanistic in my approach, and I laugh when I say that because there's this myth of humanistic therapy. There's a saying, I think, when you know nothing about clinical therapy, you're a humanist, or you practice humanist therapy. But really, in palliative care, if you think about it, it affirms that basic principle of self-actualization. It understands distress in the context of human experience. It's really focused on goal setting that's unique to the individual and where they're at in their life. So really, this idea of humanistic therapy or this humanistic approach is so powerful and so important. And I'm sure everybody in here has gotten the point, okay, I get it, Mike, you come from a humanistic kind of perspective, because it's very true. I threw this in here just in case there's any scholars in here that are very interested in learning more about terror management theory. Has anybody heard of terror management theory? It's fascinating stuff. So we had Dr. Solomon come to hospice to do this talk about terror management theory. And it's kind of based around this idea that subtle reminders, or even explicit reminders of your own mortality, so death reminders, have this deleterious effect on mood and behavior and things like that. So I'm listening to him talk at hospice, and I'm like, well, wait a minute. If I'm a social worker in palliative care and I'm talking to people about death and dying, am I not a death reminder in myself? And what's the effect that's having on the work that we're doing? So anyways, we've had some few chats and it's been very interesting, and he said that's a very good point, but maybe what we need to do is just make that anxiety known or conscious, so bring it to a conscious level. So, making it by saying it must be hard to not think about the end of your life in the presence of me, and talking about that. So kind of claiming the anxiety. It has really not much relevance for what we're talking about today, but I put it in there to remind me because it's interesting. So if you guys are interested in reading more about that, it's fascinating stuff. Okay, so getting into the good stuff. Legacy and life work. Cannot talk about legacy and life work without talking about Erik Erikson. Being in my undergrad in psychology, we talk about Erik Erikson, and we talk about these things, and right out the other ear. It's like, yeah, enough theories and stages and things like that. But man, when you're working in end of life and you see this stuff, it's so true, and it's actually pretty incredible to see. So basically, it's these last two stages, generativity versus stagnation, which is that beautiful question of, can I make my life count? So worrying about what am I leaving behind for future generations. So that's kind of where legacy work will come into what I'm talking about. And then the other question about integrity versus despair, which is the final stage, which is that question of, is it okay to have been me? So it's that retrospective look at my life, my accomplishments, and wondering have I made, what does this mean of my life? So my thought was, is it possible to use these life moments and legacy work and using this philosophy of which that I kind of focus on in palliative care to really address sadness and anxiety, but also tip the scales a bit and tip the scales towards generativity and integrity. And I'll talk about how we do that now. There was a Harvard philosopher, Josiah Royce. She wrote The Philosophy of Loyalty, and basically what she wrote about is that we all seek a cause beyond ourselves. Whether it be a big cause or a small cause, it has to be something that we ascribe meaning to and see as it's worth making sacrifices for, and it gives us meaning. So when we think back to Carstensen and how she talked about how much time we have, how we spend our time is dependent on how much time we believe we have, it makes me think of clinical work and direct work at end of life. And the reason I say that is because we can spend our time using our clinical skills to address, try deep breathing, do these types of things. We can spend time doing paperwork in terms of let's do some advanced care planning and things like that. But maybe a bigger task for social workers at end of life would be working with people to attach them to a purpose that will motivate them to continue living until they die. And I put this other point on here, which is we need devotion to something more than ourselves, because without that, we only have our desires to guide us, and at end of life, those desires are fleeting. And so this goes right back to the question when my students tell me, no, the goal of palliative care is a good death. And I say, absolutely not, it's a good life. And so I think the goal of palliative care should be, what are we doing to attach people to that life and figure out what is life to them and what is living to them. Bill Thomas, he wrote about an effective antidote to helplessness and hopelessness is reconnecting patients with something that might provide them continued purpose and meaning. And so I think this all comes into the role that social work can play. So I'm going to give you some examples of legacy work. Legacy work, again, it's that idea of working with families to have them leave behind something that's important for their loved ones. So I'll go through a few, and again, this can be an open conversation. I've learned so much coming to conferences and hearing from other people with different ideas of what they do for legacy pieces, but here are some really interesting ones that I've used personally, and I've had some pretty incredible results from it. There's a ceramic program, so basically it's a franchise. I'm sure they have them up around this area too. The idea is they provide hospice with ceramics, so bowls, plates, Christmas bulbs, things like that. Families can paint them. They can put handprints on them, lip prints, they can put thumbprints. They do all these really great things, and then we can get it glazed in a kiln, and it becomes a piece the family gets to keep. And I know the concept behind that might sound sad, but to see the joy it brings families when they're doing it is incredible, especially when you have, you know, a parent with a young child or a grandparent with their grandchildren, and they're all covered in paint, and they got kiss marks all over their face, and they have all these bowls and stuff. It's incredible. And it's a piece that the family is going to have for the rest of their life. So that's a very important one that we use. Letters or instructions, this is, I mean, it seems kind of, you know, P.S. I love you, but the instruction thing is really neat. I was working with a gentleman, and he was like, oh my God, when I die, my wife's never going to change the clock on anything in this house. And, or she'll never know how to get that pilot light on the furnace going again. And he was joking about it, but it was really a cause for a lot of his anxiety, was worrying about his wife. So I said, well, what if we just made an instruction manual, and you have everything you're worried about? Let's spend some time over the next, you know, few weeks. Let's write this instruction manual for your wife. And sure, okay, I'll do it. So he ended up writing this instruction manual. So when I think of the anxiety he was probably experiencing, if I would have said, oh, you're right, you know, that I understand that, that's why you're feeling worried. Have you tried deep breathing? Oh, what usually helps you when you feel anxious? Have you watched Family Guy? You know, so you can, but then you think of that, but then you think of the idea of, why don't we make an instruction book that he's going to have purpose, he's going to have meaning, he's going to work on this. And what do you think is going to resolve the anxiety more? His deep breathing when he's feeling anxious, or doing something like this? Right? It just takes a minute. Honestly, it takes a minute to pitch the idea. Music, again, very big. We have the music therapist who'll come into hospice, he'll sit with the kids, or he'll sit with anybody really, and he'll record an album, or he'll make a lullaby album, which is pretty fantastic. So we had a gentleman he was a singer all his life. In fact, we have a residential home, and it's an 8-bed residential facility, and it's usually for people who have a prognosis about 3 months or less. And